Hi, everyone. Welcome to today's seminar on optimizing the opioid settlements. I am Rachel Warner, the Executive Director of Penn's Leonard Davis Institute of Health Economics. Today's seminar is being co-hosted by the Center for Health Economics of Treatment Interventions for Substance Use Disorder, Hepatitis C, and HIV, also known as CHERISH. We have a lot to talk about today, and I'm looking forward to learning from the great experts who are joining us. We are lucky to have a great panel of esteemed guests. James Donahue is the first Deputy Attorney General in the Pennsylvania Office of the Attorney General. He joined that office in 1985 as the Executive Deputy Attorney General for Public Protection Division. He helps oversee the opioid settlement litigation here in Pennsylvania. Christine Minhee is an attorney and is founder of opioidsettlementtracker.com, a project she launched in 2019. The website is a comprehensive source of information about opioid settlements and states' opioid settlement spending. She is also a legal and policy consultant and advises government and nonprofit organizations. Rosalie Pakula is Chair of Health Policy, Economics, and Law at the University of Southern California's Saul Price School of Public Policy, where she co-directs the Opioid Policy Tools and Information Center of Excellence, also known as OPTIC. Rosalie is a national expert on the policy and economics of opioid treatment and recovery programs, and currently serves on a National Academies Committee reviewing this topic. Josh Sharfstein is Vice Dean for Public Health Practice and Professor at Johns Hopkins University. Previously, he served in a number of health policy roles, including the Secretary of the Maryland Department of Health and Mental Hygiene, the Principal Deputy Commissioner of the FDA, the Commissioner of Health for Baltimore City, and as a health policy advisor to Congressman Henry Waxman. Today's panel will be moderated by Shoshana Aronowitz, who is an LDI Senior Fellow, a family nurse practitioner, and assistant professor at the Penn School of Nursing. Her community-engaged research examines innovative delivery models to promote equitable access to substance use treatment and harm reduction services. So Shoshi, I will turn it over to you. Thank you all for joining us today.
Thanks so much, Rachel. Hi, everyone. Happy Friday, and thank you so much for being here with us. So according to the CDC, the number of drug overdose deaths increased by nearly 30% from 2019 to 2020 and has quintupled since 1999. From 2019 to 2020, there were significant changes in opioid-involved death rates. Opioid-involved death rates increased by 38%, prescription opioid-involved death rates increased by 17%, heroin-involved death rates decreased by 7%, and synthetic opioid-involved death rates, excluding from methadone, increased by 56%. The crisis has been evolving over time, and recently more people are using drugs such as stimulants in addition to opioids. It has become a polysubstance overdose crisis. Thankfully, there is a recent influx of funding to states and counties from opioid litigation, providing new resources to help combat the crisis. And states and counties are in the process of deciding how to disperse an expected $50 billion awarded from these lawsuits, including $26 billion awarded as part of the national opioid settlement. Settlement funds could save lives and mitigate lifelong harms if they are allocated well. States and communities have one chance to get the allocation right and to avoid some of the missteps that substantially diminish the public health impact of the tobacco settlement, including most states not using the dollars to fund tobacco prevention and cessation programs, a missed opportunity to address the greatest cause of preventable death in the United States. Based on these missteps with the tobacco settlement, the opioid settlement funds come with guardrails. States must spend at least 70% of the money for opioid-related expenses, including expanding access to treatment and buying the overdose reversal medication naloxone. In addition, 15% of the funds can be used for administrative expenses or for governments to reimburse past opioid-related expenses. This leaves 15% for states to spend however they like. We're here today with 4 experts to understand more about this historic settlement and others to come, how the resulting funds could be best used, and what it means to the millions of Americans impacted by opioid and other drug use. So, Christine, I'm going to get us started with a question for you. You've been tracking the opioid settlement cases since 2019, so I'm going to ask you to set the stage for us. In February of 2020, the National Settlement Agreement was announced. This agreement secured $26 billion from 3 distributors and Johnson & Johnson. These funds will go to the 48 states that have signed on to the agreement. Can you talk broadly about what those states agreed to? For example, the agreement specifies remediation funds to address the use and misuse of opioids, and abatement funds, which is money set aside for future remediation. And it also includes a list of suggestions for how to spend the opioid settlement called Exhibit E. Why these categories, and what's important to know about these aspects of the agreement?
Thank you so much for the question. I'm totally happy to kick us off. Happy to be on this panel as well. I'm grateful to you for name checking what I call the big tobacco nightmare at the outset in the introduction, because certainly that's the reason why I'm here and doing this work and speaking to you all today. This $26 billion deal that you're describing, it sits between the big three distributors, as you described, the McKesson, AmerisourceBergen, and Cardinal Health, and also one manufacturer, Johnson & Johnson. And this deal settles opioid crisis-related liabilities, and it settles these liabilities with two sets of government plaintiffs, the state's attorneys generals, and also the cities and counties litigation, which for the most part have been lassoed together in what's called a multi-district litigation based out of Cleveland. I'm a student of the big tobacco nightmare, which I like to describe and define quite narrowly. The paradigmatic point that less than 3% of big tobacco master settlement agreement monies, which depending on which valuation you're using is worth $206 to $246 billion. The first aspect of this nightmare being that less than 3% of those monies were actually spent on the reasons why states AGs went out and sued in the first place. And the slightly lesser known fact, and this comes from the Campaign for Tobacco-Free Kids annual and paradigmatic report, in 2022, at least, the top 3 states in treatment and prevention spending outspent the bottom 47 states combined. So that's the big tobacco nightmare. And the 70%, 15, and 15 you're describing, I see as baseline protections against this big tobacco nightmare. What you had described, that 85% of this $26 billion pie, of a state's slice of this $26 billion pie, that they have to spend at least 85% on opioid remediation. You would explain this beautifully. Opioid remediation is defined quite broadly. I mean, it includes the abatement stuff, right? The abatement interventions, but also reasonably related administrative expenses, and also reimbursement for having expended these monies for those causes in the past. The reimbursement is capped at 15%. And the truly big tobacco nightmare slice of monies, the stuff that can be spent on like roads and in North Carolina's case, subsidies for tobacco farmers, that's capped at 15% as well. So as somebody who came into this space, chicken littling about the potential for mishap here, I'm quite happy to see those things. It is important to note that the list of opioid remediation uses that's included with this settlement agreement, it's called Exhibit E. It's a 15-page document. If y'all want to visit it, I have the URL. It's bit.ly, so bit.ly/distribdocs. If you do Control F for Exhibit E, you'll get there. Importantly, it's described as a non-exhaustive list of interventions. So naturally, states have been within their own spending plans articulating which sets of interventions, which subsets are their priorities. States have been issuing what I like to call their hot new remix tracks of Exhibit E to articulate their particular priorities.
Wonderful, thank you. I wasn't sure if you had more to say there, but that's so helpful. Okay, thank you. James, I have a question for you. You had a front row seat in Pennsylvania as Attorney General, and now Governor Josh Shapiro negotiated and signed on to the master agreement with the distributors and Johnson & Johnson. The Attorney General's office has since secured additional settlements with CVS, Walmart, Walgreens, Teva, and Allergan. All 67 counties have signed on to participate in the master agreement. What stands out in particular to you about the process and the outcomes? Oh, you're muted still, can't hear you.
Sorry. Anyway, in our typical case, we sue somebody, we get the money, we get an injunction, we write it, we take that check and we give it to the Treasury, or we give it to the state agency on whose behalf we sued. As has been mentioned here, most of this money is supposed to go for abatement. So that's one thing that is atypical. the settlement, and that we're going to spend the money in the future to address the problems that exist. Another thing that's sort of that's different here, and it's been mentioned that the importance of Exhibit E. Exhibit E was put together with the help of Professor Sharfstein and health departments in Pennsylvania and Illinois and Massachusetts and New York. The North Carolina AG is sort of, cobbled it all together into the different categories and that sort of stuff. And you have 100 different uses that are meant to address the problem here. The other thing that is unusual here is, at least in Pennsylvania, 85% of the money is going to local government entities. And one of the things that we heard again and again, and this was somewhat, I guess in response to criticisms of the tobacco settlement, is that the localities didn't have any sort of input as to where the money went. I think that's important for a couple of reasons. One is the crisis isn't homogeneous. When I started this case 6 years ago, or actually more than 6 years ago, in most of Pennsylvania, the crisis was about diversion of prescription drugs, legitimate drugs used for a legitimate purpose that had been diverted. But in places like Philadelphia and Chicago, that crisis had already migrated into using an increase in illegal drugs. So by having the local focus and empowering the local municipality, counties and municipalities to make decisions about how to spend the money, we thought that was important. You said it earlier. There's one point to get the allocation right. There is one sort of master allocation among the states and among the municipalities in Pennsylvania. But each year, they're going to have to vote on, okay, well, we're going to spend this money on treatment, or we're going to spend it on wraparound services, we're going to spend it on, education. That will be a continuing process over the life of the agreements.
Wonderful, thank you. Rosalie, on to you. So states and communities have one chance to allocate funds and to avoid some of the missteps that substantially diminish the public health impact of the tobacco settlement. The Opioid Policy Tools and Information Center of Excellence, the center at RAND that you co-direct, has conducted research on how settlement funds could save lives and mitigate lifelong harms. What approaches does your group recommend states take to accomplish these goals, and what would you like to see them do?
Well, thank you. And let me start by just reiterating a point that James has already made. The crisis across each of these states is really heterogeneous. No two states are alike in how they're experiencing the harms. And then there's further heterogeneity down at the local level. So the specific strategies that we would recommend via Optic to any particular state or locality really depends on the unique circumstances of that state locality. That said, the MSA Exhibit E, which we've already mentioned several times, provides a nice comprehensive list of 8 really broad strategies that research has generally supported to be important and in identifying effective and cost-effective strategies to help mitigate the harms. And there are a few general activities that I'm confident would be beneficial to nearly all communities. The first really being increasing the amount of naloxone available in communities and putting those doses in layperson's hands, first responders' hands, and healthcare provider hands. These extra doses are critical, not just because they can save a life, but in the case of fentanyl, it's often the case that one dose is insufficient. We need extra doses out there, and people might not be aware that that's what's needed, particularly in the hands of lay people, like for Narcan, where it's easily administered very easily by someone who might not be educated, or the more sophisticated injection ones for first responders and the like. The second strategy that's really important from our perspective is increasing availability of an immediate access to, and that's key, immediate access to evidence-based drug treatment. And I say drug treatment because while opioids was the initial driver, as has already been said by Christine and yourself, this is really a polydrug addiction problem today. And while medication for opioid use disorder is known to be incredibly effective and safe, even for pregnant women, it is not a useful strategy for managing addiction related to meth and cocaine. And given that today's crisis is driven by fentanyl, which is being mixed in with these other substances, we need to have a treatment system that's ready to handle the main addiction that people are experiencing, not just the drug that led to their overdose that might connect them to treatment. So there's a number of ways of increasing this availability and immediate access that are outlaid in Exhibit E, but ones that we know are particularly important given the research is providing linkages and warm handoffs to treatment through the ER, through first responders and elsewhere in the community, expanding the treatment workforce and making sure that workforce has the capacity to manage the demand in given areas. Sometimes that can be done by borrowing workforce from other areas through telehealth, but sometimes it requires just getting more people. And given the COVID experience, we know that this is a critical issue today. It's also an issue of making this treatment more affordable for those without insurance or for those whose current insurance doesn't cover the cost of treatment. Medication for opioid use disorder or even contingent management, which is a very effective strategy for methamphetamine and stimulants. These are not cheap therapies, but they need to be covered for those in need. And then providing those wraparound and recovery support services to make treatment stick and to help people sustain a healthy recovery. This really should be thought of as a part of treatment, an extension of treatment. Those services are not currently covered by health insurance and need to be. One final area that we know it will be important for tackling this problem, regardless of state and communities, is prevention. And when it comes to prevention, one of the easiest and cheapest ways of promoting prevention is really funding outreach to medical providers and medical provider education on best prescribing practices for opioids, but not just opioids. I would argue that we would want to extend this to other drugs as well. Several studies at Penn, USC, and elsewhere have basically shown that simple letters to providers can have enormous changes in how they are prescribing opioids, which is important because prescribers could have been trained 20, 30 years ago with a very different philosophy on the addictive potential of these drugs. But I would argue that these same strategies could be effective potentially at preventing overprescribing of other substances that could be misused. Percocet, Valium, and even Adderall, which are becoming a complicating part of this polydrug addiction crisis that we're reaching today. So those are the primary broad strategies that I think would be effective anywhere.
Thanks so much, Rosalie. Okay, Josh. So other panelists have outlined a number of approaches and actions that the settlement funds could be used towards. Your institution, Johns Hopkins, has developed the principles for the use of funds from the opioid litigation. Can you talk about the history and goals of these principles?
Sure, and thanks for having me. It's great to be on this panel. I think this started with when the settlement started happening and the realization that relying on the usual process for approaching this difficult issue was most likely not going to be that successful this time. And it's because it hasn't been successful before. The reason, in my view, that we have such a horrible problem with overdose is that it's not a lack of good ideas or evidence. It's that we often don't put those ideas and that evidence into practice. And the reason for that has to do with the politics of this issue, the stigma that exists on addiction, the fact that sometimes the people who are the most persuasive at the state and local level are not people who are actually advocating for evidence-based solutions, but actually, in some cases, could be advocating for programs and approaches that make the problem worse. So sometimes you put in money and you get on the end of that more overdoses. So the question was, how do we have a process that allows people to say, well, let's look up that RAND report and see what is actually evidence-based to reduce overdoses, and really takes into account the views of people who have been affected and have been suffering from this overdose crisis for many years, rather than relying on the same old answers that have not been that successful. And so we worked with more than 60 organizations now have signed on. We work with dozens to put them together. The 5 principles are pretty straightforward. Spend the money to save lives. Like Christine said, do not spend the money on other stuff, like what happened with tobacco, use evidence to guide the spending, which actually is not what happens often, but actually have evidence to inform the decisions that are being made. Number three, invest in youth prevention. I think there's a realization that better prescribing is an important part of prevention, but not all of prevention, and that young people, if they're not going to get involved with prescription drugs, can find other paths to addiction that can knock them off their life's trajectory if they don't have the access to a supportive environment. Sorry about that. And so there are, the fourth one is to focus on racial equity because of the incredible inequity of the addiction crisis for many decades. And then the fifth one is to develop a fair and transparent process for deciding where to spend the funding. And, that principle has been a little contentious as these have been implemented, but we think that's important for people to say, we want to understand where this money is going, want to understand whether it's based on evidence or not. And part of that process isn't just, people with ideas voting. It's looking at the situation in your county or state to see, where are there, is it a place where there's a lot of cocaine, or is it a place where it's mainly opioids? What's the nature of the challenge, as well as the policy environment? What is the story with laws that may make it harder to actually provide evidence-based treatment or evidence-based harm reduction? Can we change those laws to make these settlement dollars go further? And then, of course, part of that context is the fact that there's a lot of federal money coming to states and localities around the overdose crisis. And how do these investments complement that? Like, for example, SAMHSA has been putting a lot of attention on naloxone, but there may be other investments that can complement naloxone or get the naloxone to people who are super high risk of overdose and people who would be with them when they're at risk for overdose, that might complement the actual naloxone purchases that SAMHSA is making. So don't, think of this as being in a bubble. And so those process issues become really important. That's why we put this together. And the response has been really tremendous. And, encourage everyone to check out opioidprinciples.jhsph.edu to see the principles and all kinds of guides for advocates or states. We're going to be releasing our first awards for the places doing it the best, we think, pretty soon.
Thanks so much, Josh. That was really great. And it sets the stage well for some questions that I'd like to pose to the group, and anyone can jump in. And they also touch on some things that Josh started to talk about and what I'm seeing audience members in the chat want to hear about. So the first is the impact and policy responses to the opioid overdose crisis have been transformed by the COVID-19 pandemic. Inequalities and structural and systemic racism have exacerbated the burden for certain populations. The CDC recently reported that drug overdose data show troubling trends and widening disparities between different population groups. In just 1 year, overdose death rates increased 44% for Black people and 39% for American Indian and Alaska Native people. A lower proportion of people from racial and ethnic minoritized groups receive treatment compared with white people. How can the settlement agreements best address these disparities? And then a follow-up question to that for anyone who might want to jump in is that many people who died by overdose had no evidence of substance use treatment before their deaths, in many cases likely because they were recreational drug users who encountered a tainted drug. How can the settlement agreements address this toxic supply issue?
So let me, if I can start on some of these issues in terms of the racial equity, and which is something that we're very focused on here in here in Pennsylvania. And when we've started to do some more outreach in minority communities about the services we offer to people in terms of addressing healthcare problems, but there are several aspects here that are designed to serve those exact things. So you start with the increased use of naloxone coupled with training. You have the addition of wraparound services. And the idea of those wraparound services is, if you can't get to your appointment, where everybody talks about MAT being the gold standard, which it is, but MAT is just not the drug. It is the drug and the counseling together that makes it work. So you've got to put people together with the providers by providing those things like wraparound services. That was specifically targeted at low income, rural, and minority communities that might not have the access to transportation. Now, again, it comes down to the local leaders who can use this money in this way, but we tried to create a structure where we specifically were targeting, those types of problems. The same thing in terms of neonatal abstinence withdrawal syndrome. That's something that this can be used for, and that is another issue that arises in low income and minority communities.
Yeah. Go ahead.
Go ahead, Joshua.
I would just jump in really quickly to say, I think that the agreement makes this possible. It makes it possible to address some of these inequities, but it does not guarantee that they will be addressed. And that's partly why, from a process perspective, we recommend that communities that have been overlooked in the response, that have been targeted in some cases, punitively in the drug response, particularly minority communities, have a seat at the table, be very involved in making decisions, and that explicitly the goal of enhancing racial equity should be there, so that as the investments and other policy decisions are made, you can see whether it's working and circle back. And that requires a great deal of transparency for that to happen.
Yeah, and I would just echo a point that Joshua made earlier in his 5 principles. In many cases, it's the law that it makes minority populations distrust the availability of some of these services. For example, some of the recovery housing does not allow you to be taking any opioid in order to sustain housing, but methadone and buprenorphine medications are also can get put on those lists, and people can get taken out of recovery supportive services for adhering to an evidence-based treatment protocols. So there are structural barriers in our laws that have disproportionately harmed some of these communities that are now being targeted with these settlement funds. But these laws need to be addressed so that we can focus on actual treatment and resolution of past harms, as opposed to introducing new harms for these people we're trying to help.
Yes, I'd like to add, and I echo so many of the sentiments of my co-panelists, particularly the including these folks at the decision-making table. Nothing about us without us ought to be the touchstone here at all times. There is a lot of potential to go off on a Molotov cocktail brewing social justice warrior rant as a young woman of color. I think at all times, never forget that the fastest way to figure out what they would like is also to ask them. There's a lot of reporting live from what I've heard from advocates on the ground. There's a lot of chatter about who ought to be sitting at these in these advisory committees overseeing opioid abatement funds, or who ought to be a part of advisory councils. And does a task force include the right people at the table? Does it include the right types of perspectives? Lots of potential for identity politics here. The tip that I'll throw out there is, and this reveals my training and my bias, I guess, because I'm approaching this as an attorney, would look at the language surrounding the valence of these recommendations, right? We want to make sure that when these perspectives are included, they aren't tokenized. They aren't further tokenized by just being included in a community feedback PDF and then, set asidable by the legislature. We can't have that. We want recommendations with high valence, recommendations that are sticky, that the legislature can't just look at and say cute and just set aside. There has to be a process to back up the desire to include folks at the table. And also exactly what Rosalie said. I mean, there are a lot of things that settlement funds can help with, but a lot of structural inequities that are baked into state statutes as well. So keep an eye on the ways that the candle can be burnt from both ends, I guess. Yes, this is a massive cash infusion that ought to be used in a forward-looking way that will heal us moving forward rather than exacerbating the division and the chaos that brought us here. But also, I would encourage states to do a check-in, a retrospective, like what are the actual statutes that are enabling progress here and what are the things that might not be helping?
Wonderful. Thanks, everyone. So I'm just going to keep throwing out questions that anyone can feel free to answer. There's been a lot of great questions in the chat, both about how to incentivize utilizing evidence-based practices and also consequences for municipalities who choose to invest money in non-evidence-based strategies. And one audience member mentioned, for example, forced residential treatment. So what are the legal checks and balances and who's responsible for actually implementing oversight over these things?
You know, what I would say, and I'd be curious what other people think, is that this is fundamentally a political process. You know, there's if it's a legal thing to do, and the agreement is pretty broad, that if the political process produces something that doesn't work, which is entirely possible because it has produced things that don't work many times in the past, then that's going to happen. There's no special appeal to somebody who is going to say, actually, you know, the governing document is the RAND report, you know, and it's not in the RAND report, so it won't get funded. Like, that doesn't happen. It's political. And that's why it's so important for people to be involved in the process and demand that the process be structured in a way to produce the best outcomes. And, you know, I think it is enormously frustrating when, for example, you know, people may be funding tactics that have failed again and again, or types of treatment that very clearly increase the risk of overdose. And I'm thinking of treatment that requires people not to be treated with medications for opioid use disorder, and then puts them at enormous risk after they lose their tolerance for fatal overdose, higher risk than probably when they went in. You know, in some cases, and there's definitely evidence on that, like, that's what happens. That's what our political system can produce if we're not vigilant, if we're not engaged. And, you know, we want to minimize that as much as possible. There's litigation in Ohio now because despite the state asking a nonprofit to talk publicly about its decision-making, they concluded that they didn't have to do that. And so I think the harm reduction groups in Ohio are now suing. I think it's the right thing to do to challenge processes that could be on a road to recapitulating some of the failures of the past. I wish there were that appeal process, but I don't think it exists.
But I would also like to add to that, there's defining things as evidence-based is kind of a squishy road too. The reality is some of the best strategies right now being tried out there are in fact not yet proven to be effective. We're collecting the pilot data to demonstrate that, and that doesn't mean the community shouldn't be doing those things if there's a high degree of evidence suggesting they should be effective. And by this, I mean things like drug testing that's going on in several local communities to check for fentanyl. That can have a huge impact on avoiding an unintended death for someone who doesn't think they're consuming opioids because they have a Percocet pill, but can identify a risk that they wouldn't otherwise know about. How do we measure the effectiveness of that? If we're only looking at opioid-related mortality in the given area, if the fentanyl moves to a different drug, we might be missing something. Another example are safe consumption sites and safe injection rooms, which the evidence there has been mixed in some locations, but more recent evidence of more qualified, quote, better studies with better statistical techniques and the like are suggesting they are effective. And so it does take time for science to sometimes catch up with some of the really innovative ideas. And we shouldn't discourage communities from pursuing things where the science is unclear. It doesn't mean that it's not effective. It just means the science hasn't had enough evidence to come out definitively on its effectiveness.
Jean, do you want to jump in? I see your hands up.
Yes, thanks. I saw James go off mic first, so I thought, okay, so related to that.
I'll go next. Go ahead.
Great. I'll try to do the TLDR version. Sometimes I get emails from folks in particular states, and they email me and they say, hey, data lady, can you export that part of your spreadsheet that tells me exactly how much my state has spent on X units of naloxone for this time period? And can you tell me if that's typical? And my deepest core is like grieves for that moment. And then the outside is like, oh, you sweet summer child, because what we're heading into an absolute data desert, one where we're going to have a lot more information about how we got here. UCSF's opioid industry documents archive. We're going to have at least not paltry information about how this crisis is continuing to hurt us. Morbidity and mortality data being baseline measures. There have to be tremendously more parameters to measure what true impact is for at least within federal programming and dashboards. But in any case, we're going to have a lot of data about how we got here and how this crisis is continuing to hurt us. But we aren't going to have very much data at all about how these settlement monies are actually being spent. Something that might be a dirty secret about the settlement requirements are that public reporting of opioid remediation expenditures is not required. The only public reporting that's required under the settlement agreements goes to that 15% of funds that can be spent on non-opioid remediation things. And there's a Wilmington Trust that needs to report that out to the public, and we're supposed to hear from them sometime here in the next few months. But in any case, this is a huge concern of mine. I'm happy to pick up like the part 2 of this explainer if it's more pertinent to the second question, but I'm working on a 50-state survey of states' promises to publicly report spend. By working on it is complete. And as of 10 minutes before this presentation, I was told that I am able to announce that I am doing a data partnership with Kaiser Health News to get this out, sing it from the rooftops. The data we'd like to sing from the rooftops is that a very depressing amount of states are actually committing to publicly reporting 100% of their opioid remediation expenditures. The visibility into what these monies will actually be spent on is quite low. So I promise, as you know, my fellow co-panelists are working on the evaluation and assessment of what actual interventions ought to be funded. Like the work that I'll be doing is let's raise all ships here and encourage the states who are reporting expenditure data up to some body, like some oversight body, an advisory committee or advisory council. Let's encourage those states to then report those expenditures out as well, so we, the public, can actually see what these monies are being spent on.
So I was going to say, we were acutely aware that, as Dr. Sharpstein said, this is a political process in terms of how the money is spent. Now, what we did in Pennsylvania, and I don't have a good sense of what all 50 states did, is we set up a trust. The trust is set up by the court. It's supervised by a court. And there are annual reporting requirements about exactly what money is being spent. And there's punishment if you don't spend the money consistent with Exhibit A. Part of me wanted to, in drafting, in the role I played in drafting Exhibit A, was to, make it, this is it. We've consulted experts all over the country. There's about 100 different things here. This should be it. We don't need to mess with it. Now, that would not be recognizing that this crisis is going to change over the time here, and you may need to either add things or subtract things from that list. But I think from my perspective, to the extent people want to vary from Exhibit A and go to types of programs that are not supported by evidence, or and that are not really legitimate types of experimental programs to try to test and see if something better would work. We have to be very careful about allowing those types of variances there. But we have tried to work and put in some safeguards to ensure, at least in Pennsylvania, that there is a lot of control. One other thing I want to say here is that because of the nature of this crisis and the impact here, and it's been pretty broad in terms of economic classes and racial classes and that sort of stuff, we've had a number of meetings with all of the municipalities and counties and that sort of stuff, explaining how this is going to work. The feedback we've gotten has been very sincere, I think, from the elected officials about the desire to use the money appropriately and get effective results. And the reason for that is Many of them have family members and neighbors who've been affected by this crisis. So it's a little bit different than some other types of, issues that we faced politically in the past.
I would just to jump in on that. I agree with you. There is a lot of interest and bipartisan interest, and it's genuine interest. I don't think the issue isn't that people aren't well-meaning when they're trying to address this. It's just that oftentimes the sources of authority, the people who decision makers turn to in communities, may not be operating from evidence. And I don't necessarily, I'm not saying it has to meet the absolute highest standard, but we're talking about maybe going in a direction that is very, very clearly not supported by evidence. And it may be a local police chief who's doing things the old way, and that person just has a lot of credibility. Or it could be people who fundamentally think that it is not a chronic illness, that I just wish that, my child had been able to get a discrete period of treatment and then come back the way they were before, which you can totally understand. But it's actually hard to square with the fact that addiction is a chronic illness and long-term treatment is sometimes necessary. The challenge isn't to get people to care. The challenge is to be able to have a process that you can talk through, you can look at the laws, you can look at all the investments and say, are we really lining this up with what we think will have the biggest impact? And can we show that? Can we show that there are things that we're looking at that make sense? And you could have an argument that it's promising. Is that argument based on data? Are people able to get the core things that are absolutely necessary? In some of these communities where these decisions are happening, you go to an emergency room, you can't get addiction treatment. You could show up at a health department, there's no naloxone to give out. So really making sure that those core things are done, because those are the things that would really matter. That's a really important focus. And even well-meaning political leaders, it doesn't guarantee that you get the right results. That's the big puzzle that has to be put together for this to work.
Yeah, look, I think the political process is the political process. I don't think anybody denies it. I think that, in Pennsylvania and in many of the states, by, sending the money out locally, you're empowering the people to, you don't have to travel to Harrisburg. You just have to go to your county seat, or you have to go to your city council meeting or something like that to talk about how the money is spent and to put your voice forward. Again, it's a political process, and there are many competing voices. We're certainly hearing from, a lot of vendors who are thinking, oh, there's all this money out here. I've invented the newest talk therapy thing, which I think is usually useless. But they'll be out there pitching that across the country.
Well, and there are people with different kinds of pharmaceutical interventions that really don't have strong data behind them, and they can spend a lot of money, they can lobby, and it becomes a big challenge for the process to work through. And the political process is extremely important. It's just really incumbent on people who want to see the right outcome and fewer overdoses to fight for this process to be as fair and inclusive and effective as possible.
And implementation really is key. For example, my colleagues at USC have been studying buprenorphine access through pharmacies. And pharmacies in poor, diverse neighborhoods are much less likely to have buprenorphine in stock behind the counter. So even if someone is willing to go see a doctor and initiate treatment and has a prescription, they can't get it at their local pharmacy. This is an implementation issue that matters, and having people who are involved in the execution, and I mean execution of the details of effective strategies, should be part of those conversations and listened to more than necessarily great new ideas that haven't been truly tried and tested. That doesn't mean that we shouldn't try innovation, but what it means is that there are some really important nuts and bolts that we can easily overcome by just thinking about how is it happening. One of my biggest concerns with the settlement is that there is a lot of money that is being allocated for naloxone purchases. My concern about that, I think it's a great strategy. My concern about that is that could drive up the prices of naloxone that communities have to pay. And then they can't afford to distribute them to first responders or to healthcare professionals or even to lay people. How do we make sure that this efficacious, life-saving drug is affordable to people when there's growing demand for it? that's an implementation issue that I think lawmakers can seriously think about and tackle in a way that the folks on the ground might not be able to.
Yeah, it might be worth just focusing on naloxone as a good example of this, because there are a lot of different ways to do naloxone policy. I just had a long call this morning. We were talking about this. And naloxone reverses an overdose. Biologically, it's very clear what it does. But how a naloxone policy where you invest naloxone, that's the product of a political process. Now, it could be that naloxone is, given out, mailed to every citizen, even if no matter what the risk that they would come across an overdose. But in fact, the highest impact for naloxone will be if you put it in the hands of somebody who will come across an overdose. And often that's done through harm reduction groups who are going to be able to reach many, many people. And that dose is going to be turned over and saving a lot of lives compared to someone who might just have it at home and never really use it till it expires. And so if you were thinking about how you have a process that's going to support the most impactful use of naloxone, you want people who can talk about, where naloxone gets used the most. You want groups that are going to be able to stand up and say, I can find those people, I can help them. This is how we can get it to them. And then you want to talk seriously about even which form of naloxone makes the most sense to get. Because in some cases where there's a lot of intravenous drug use, the intravenous vials are a couple dollars versus, $20, $30, $40 per dose for some of the inhaled versions. That may be a factor. It may make sense for a community to invest in much cheaper naloxone through and distributed to nonprofits that are going to reach people who are very high risk for dying, rather than a more general strategy. So even within this concept of naloxone, there's a lot of work to be done. You'd want to see where the federal funds are going, how that's coming in, how investment through the settlement funds could complement that and have the biggest impact in the end. And then you could monitor, well, are these doses being used? Which approach to using naloxone is actually producing the biggest results for us? And maybe we should put more money there. Just to go through this a little bit as an example, on every one of these issues, there's a lot to be talked about so that the money is used as effectively as possible.
Related to naloxone, I echo so much of what Josh has said. I want to lift something that has come out recently as an announcement. Vital Strategies has recently awarded 12 orgs in North Carolina $1.5 million to expand community-based naloxone distribution and also syringe service programs. This money would benefit grantees across 8 counties, I think. I really love jurisdictions that participate in matching programs generally. But within this discussion, I do see community-based distribution of naloxone on one end of the spectrum, and something like Teva's very top-down cash drug hybrid offer, where there's this offer of, this illusion of a shipping container of life-saving drugs that just arrives at the state's doorstep, and then the illusion that the state has all the distribution channels set up to make sure that these drugs are actually distributed to the communities that need it most. That, for the most part, is, illusory. So the careful fine-tuning of how these interventions are actually operationalized is quite key. And related to the distribution of, I'm going to stop there and pass it off to the other co-panelists, but I think that is incredibly huge.
I agree. We have had many discussions with Teva about how impractical it is to drop drugs off at a state loading dock. If for no other reason, we don't have the licenses from the FDA and the DEA to distribute that stuff. That's just absolutely. A big,
I actually, if I could take the luxury of asking a question to my co-panelists here, I specifically advocate for harm reduction uses of settlement monies. We've talked a lot about Exhibit E, and I am curious to hear from y'all. Harm reduction doesn't appear in the first 3 pages of Exhibit E, which is described as the core strategies that states must prioritize, and then the subsequent 12 pages, which cover approved purposes, describe a list that states may pull from. So core strategies must prioritize Schedule B, approved purposes may. And harm reduction appears in the second part, that is a may, under sections address the needs of criminal justice involved persons, prevent overdose deaths and other harms, and research. Knowing what we know now, is the feeling in the room that we would prioritize this as a core strategy? Has the zeitgeist changed, or is this not about a zeitgeist at all? I'm genuinely curious.
So, let me give you sort of a pragmatic example here of why, why it's set up the way it is. If you have somebody who gets in the criminal justice system and they are arrested, they are going to go to local jail. If they're suffering from withdrawal while they're in the local jail, from an overdose, they're going to be taken to the ER. The bill for that ER visit is going to go to the county or municipality who's ever running the jail. That is an enormous bill. So part of the focus on treatment and sort of the immediacy and naloxone and all those things sort of expands out of, okay, what happens at the government level at the most basic thing when somebody overdoses? Where do those costs come in the system? And that's sort of why the other things they're not really meant to be secondary, but they are a response to what people were saying. What do we need to do? Where do we have the shortages? We don't have enough treatment beds. We don't have enough doctors trained in MAT. We don't have enough MAT. We don't have enough naloxone. And that's how those things ended up first. All those other things, whether it's the wraparound services or the education, other things, those are all super important as well. I don't think it's meant that because they're in a different order that they're really meant to be, discounted. The other thing here is this is an unusual crisis in the sense that, your typical case when you're suing a manufacturer for something, you have an overcharge case. The drug was 10% higher than it should have been. You get the 10% back. This is a case where, in some cases, these drugs cost like $2 and cause $35,000, $45,000 of damage in terms of treatment costs for an individual. So we're not able to fully recover all of the money that we really need here. This is just a supplement to what's going to go on from the federal and state governments that are trying to address the problem here as well.
I would answer Christine's question from a slightly different perspective and say, in an age of fentanyl, where the drug supply is so risky, I think there's a much greater appreciation than there ever has been about the value of different types of, maybe just say more involved harm reduction efforts. I consider naloxone a form of harm reduction, but we're talking about drug checking, overdose prevention sites, enhanced syringe service programs, other things like that. I think there is a bigger appreciation of the importance of that, given the danger of the drug supply now. And the other thing to keep in mind for communities is that, for drug treatment, which is life-saving, it often can be covered through other funds. Medicaid is the big one. Medicaid should be working. That's a critical aspect of the policy environment to be able to provide adequate treatment, allowing in many places the settlement funds to be able to shore up parts of the response, including harm reduction, that aren't so easily covered with other funds. Now, in states that have not expanded Medicaid, they'll have SAMHSA funds for some level of treatment, but they may need other funds for core treatment, or the incarcerated transitions of care and getting treatment to populations that wouldn't otherwise have it, also a very high priority. But it may be that there's just less money for all the priorities in places that haven't expanded Medicaid. But I do think the premise of your question I would agree with, which is that for many, many, many places, it's going to make a lot of sense to put this money to innovative and evidence-inspired, if not evidence-based, fully evidence-authorized efforts in the harm reduction space, because particularly now, the number of overdoses and the danger of the drug supply.
If I can, I agree entirely with what Josh has just said. I would just couple it with one other little thing. I think that dealing with harm reduction policies and proposals is important for the existing current group of drug users who are in significant harm's way because of our current drug market and the lethality of the drugs that could be involved. But the treatment system is there to treat those individuals when they're willing and able to come to treatment, and prevent young users who experiment and have bad episodes, and to prevent them from having a lifetime struggle with addiction. Our addiction treatment system is completely antiquated and is held together by buckets of different funds that doesn't allow it to function fully in an efficient way. Using these settlement funds to actually shore up and stabilize a very fragile and antiquated treatment system, I think in the long run can have enormous value for the number of individuals who are going to process through, not just for opioids, not just for stimulants, but for alcohol and other substances that dramatically influence our communities.
Would you agree, Rosalie, that you don't want it to be you don't want to have to shore up something that the Medicaid program could do by itself?
Yes,
it's better to get Medicaid to work.
Absolutely. Where Medicaid is funding those treatments, or where block grant funds and the federal government are supporting it, then that works great. But there are many states and communities where it's just not.
And the other thing is, I think we should think about treatment and harm reduction as not totally different things. Right. One of the more interesting and innovative efforts has been getting people access to treatment right there in a syringe service program. The places that have done that, a lot of people want to do it, and so the concept that people have to be ready in some sense for treatment and wait till they show up and follow all the rules, isn't maybe as accurate as people thought, and making sure treatment is accessible at every step where they're coming into contact with people who want to help them really offers a huge opportunity.
But keeping in mind, people will relapse, and we can't judge them. We can't punish them. We have to encourage them to re-engage. We don't take diabetics who go off their medication and throw them in jail or create stigma around them. We treat them.
This is an incredible conversation, and there's been so many wonderful questions in the chat as well. So I apologize for not being able to get to all of them, but I was just looking at the time and realizing that we're so close to 1 o'clock. So Rachel, I will hand it back to you because I want to make sure we can end on time, but thank you so much, everyone.
Thank you all very much. Thanks, Shoshi. That was an incredible conversation. And a huge amount of engagement from the audience based on the number of questions that we got. So I just want to reiterate that thank you. This was really a pleasure listening to this, and I learned so much from all of you, as I'm sure the audience did too. I also want to let the audience know that we have a seminar. Our next seminar is coming up next month, and it is on examining private equity in healthcare. I hope you can join us for that as well, which I think will also be a really terrific conversation. And until then, everyone take care. Thanks again, everyone.